Hi, my name is Gregory Lamb, and I am a cardiologist with New England Telemedicine. And I want to introduce you to our next round of our virtual grand rounds. And I want to spend the next 10 minutes talking with you about the preoperative cardiac assessment for non-cardiac surgery patients. What specifically I'd like to do is talk with you about the 2014 ACC-AHA updated guidelines for the preoperative assessment of non-cardiac surgery patients, and to talk about one of the clinical risk assessment tools in particular, the ACS NSQIP. I have no disclosures. Um, Cardiac assessment can be kind of tricky, and there's multiple ways to think about it and to perform it. Historically, we think about the four active clinical cardiac conditions, including active chest pain, congestive heart failure symptoms, severe valvular abnormalities, or severe dysrhythmias. If they had any of those conditions, we'd stop, do a cardiac assessment, and not go into surgery. If, however, they didn't have any of those symptoms, we then ask, well, are they going for a low-risk procedure or a non-low-risk procedure? And the way that we think about that before was low-risk procedures are anything that carries a less than 1% risk of MI or death. And those would include endoscopic procedures, superficial procedures, cataract surgery, breast cancer, or any ambulatory surgery. And any of the intermediate or high-risk surgeries, so the non-low risk procedures, are any vascular procedures. By definition, those are considered high risk. Um, any intraperitoneal or intrathoracic surgery, head and neck surgeries, prostate surgeries, or orthopedic surgeries. And so if they were going for low risk procedures, they could go ahead with the surgery because of the low perioperative risk. On the other hand, if they're going for non-low risk surgery, then the next question we ask is, well, what's their functional status? And in this case, the magic cutoff is 4 metabolic equivalents. And as you recall, 4 metabolic equivalents would be the equivalent of being able to climb a flight of stairs without developing any symptoms. Things like walking briskly on flat ground at approximately 4 miles per hour, running a short distance, moderate to heavy household chores, or things like throwing a football or throwing a baseball. Now, if their functional capacity surpassed that of 4 metabolic equivalents, then they could go ahead with the surgery. If it didn't, then the next question is, well, what is their perioperative risk? And to help us assess the risk, there's a number of different tools out there. Some of them you may be familiar with are the Revised Cardiac Risk Index, or the one that we'll be talking about a little later on, the NSQIP risk calculator. Now, if those tools deem that their perioperative risk is low, less than 1%, then you could go ahead with the surgery. But if not, then other pharmacologic testing would be recommended. Well, now in 2014, the ACC and the AHA came up with their stepwise approach to cardiac assessment. And this is how it looks like. And it looks like a lot, but what I want to do is spend the next few minutes going through each step individually. And the first step is to ask, is this an emergent surgery? If it is, then there's no reason to do any other cardiac testing and just proceed along with the surgery. But the other question they ask is the patient having any signs or symptoms of acute coronary syndrome? And if it is, then the recommendations would be to perform the guideline-directed medical therapy. If the patient doesn't appear to have an emergent case or doesn't have an acute coronary syndrome, then the next step, according to the 2014 recommendations, is to then assess their perioperative risk of MACE, which is the major adverse cardiac events. And in this case, this is where our clinical risk calculator comes in handy. The one that cardiologists tend to gravitate towards nowadays is the NSQIP, otherwise known as the Gupta tool. And I've included the URL here. You can go online, and this is a very handy web-based risk calculator where you plug in the procedure that the patient's going to have, some of the patient characteristics such as their height and weight and other medical comorbidities. And then what it does is it calculates out their risk of any complications, serious complications, cardiac complications. And in this case, I entered in a fictitious patient, age 74, with diabetes, hypertension, congestive heart failure, with some shortness of breath, a smoker. And in this case, they actually figured that the cardiac complications is about 8.2%. The average risk is 2.7%. Their cardiac complications is 0.6%, which is actually slightly greater than the average risk of 0.1%. Well, what does that mean? And so according to the ACC-AHA stepwise approach, if it's less than 1%, which this patient is, they can go ahead with the surgery without any further cardiac testing. On the other hand, if you deem that their perioperative risk is high, Then we move on to the next step, which is then to assess their functional capacity. Here again, 4 metabolic equivalents is the magic cutoff. And if they surpass 4, then they're good to go with the surgery. Um, on the other hand, though, if they're not, so if their functional capacity is poor, is less than 4 meds, or is not known. So for instance, a lot of times our patients with hip problems, they haven't been active for years to months. And so we don't know what their functional capacity is. Now, when you hit this point, then you reach a decision point, a branch point. And the question is will further testing impact your decision making, or will it affect perioperative care? And in the vast majority of cases, the answer is no. And the data for this comes from the mid-2000s. So in 2004, the CARP trial came out. It was published by McFalls et al. And what they did was they looked at vascular surgery patients and they asked whether or not revascularization or not revascularizing them, just treating them with optical medical therapy, if that affected outcomes. And it didn't. And this then led to the question in 2006 by Potermans whether or not cardiac testing made any difference at all. And what they did was they looked at outcomes based on cardiac death or myocardial infarctions, and looked at patients that had testing or didn't have testing. And what they found was that there was really no difference in outcomes at all. And so in the vast majority of cases, further cardiac testing really won't affect your perioperative management or your decision making. However, in some of the cases it might. And in those cases, then the recommendations are to go ahead and perform your stress testing. In the guidelines, they actually mentioned pharmacologic stress testing. But if the patient can exercise, that would be preferable, because if they can surpass 7 to 10 meds, then that portends a very good cardiac prognosis. So that's really helpful. Now, of course, if the stress testing comes back as normal, then they can go ahead with the surgery. On the other hand, if it comes back as abnormal, well, here we reach another branch point, another decision point. And in this case, then conversations really need to be made with the surgeon and with the patient about what it means to actually delay the surgery and proceed on with further cardiac testing, such as revascularization, because that could yield a delay in the surgery, or whether or not it's in their best interest to just go ahead with the surgery, knowing the risk of potential cardiac complications. And so that sort of wraps up the 2014 guidelines. Questions may still exist. And so each case is idiosyncratic. So for instance, considerations have to be taken about the difficulties of the surgery itself, other medical comorbidities. So for instance, some patients have very bad pulmonary disease. And so do you use other risk calculators to help figure that out? What about other medications that they're on and the perioperative management of those medications? Or maybe even the utility of other cardiac testing, such as echocardiograms, cardiac MRIs, and EKGs. And to help with that, New England Telemedicine offers a perioperative clinic where we can talk with the patients and help sort through some of these issues, and then to discuss the cases with you to see what would be the best thing for your patient. Well, this wraps up our last installment of the virtual Grand Rounds. I hope this helped clarify some issues with the preoperative cardiac assessment for non-cardiac patients. I left my number there, and feel free to give me a call if you have any questions. Thank you very much.